So for this patient, she came to me having left leg pain. And on her MRI, what I saw was she was getting compression of the nerve root on the left side. Now, on this MRI, I also saw some signs that made me think, there may be a day that you need a bigger surgery. For example, when we look at this MRI right here, these things in the back are called our facet joints. So this is as if we're looking down the spine and we're looking at the facet joints right here. And what I saw on this MRI was that this facet joint on the left was very gapped. This means that there was some kind of motion at that segment that wasn't totally normal. So what I told her was that, we could do a small surgery to decompress this nerve root, to alleviate the pressure on the nerve root. There were some bone spurs causing pressure. But I did think that at some point in the future that if this progressed, she may be back to get more surgery. So that's exactly what we did. About 2 years ago, we did the smaller surgery where we just made more room for the nerve root. This was called a foraminotomy. So what we did was where the nerve root was exiting, we created more space. This is what her x-ray looked like at the time. When you look at her from the side, you can see that the L5 and the S1 segment were pretty lined up, right? L5 and S1, maybe L5 was a little bit in front, but overall it was pretty lined up. When she came back a couple years later, the very first thing I saw was that on her x-ray, the bone, the L5 bone, had gotten much more in front of S1. So the vertebrae of L5 had slipped forward even more on the vertebrae of L1. You can really see that difference between the two. What we call this is she had a progressive spondylolisthesis. Given that the smaller surgery lasted 2 years, at this point, I thought that her solution, given that her leg pain had returned, the solution to the leg pain was to actually address the source of the problem this time, which was the fact that she was getting some instability at the 5-1 segment. So what we did for her was a minimally invasive transforaminal lumbar fusion. So we realigned the L5 and the S1 segments. We reconstituted the curve at the bottom of her spine. So now instead of having like what we call a neutral segment, she now had about 16 degrees of lordosis, which is closer to the 20 degrees that we normally want here. Her leg pain got much better very quickly. She's about 6 months from surgery. So, we're going to keep an eye out, making sure the bones heal. We're going to keep an eye out for the adjacent segments as well. But right now, she's doing pretty good. This is a guy that came to me, a 7-year-old man who had had a L4 to S1 fusion in the lumbar spine with a L5-1 TLIF. So meaning what they had done is they had gone from the back into the interbody space, into that disc space, and they had placed a bone graft in a cage to get the bones to heal across that L5-S1 segment. And you can see that right here. We have the spacer here and here as well. From when we're looking from the back to front, you can see that interbody spacer. Now, this gentleman had improvement in his leg pain for about 3 or 4 months after surgery, but then it gradually came back. And he's still having that same leg pain as he had before the surgery. So when he walks, the pain still happens. So what we did for him is we got something called a CT scan. And a CT scan is probably the most accurate way that we have right now to determine if the bones have healed together. So when we were looking at his CT scan, what I noticed was that I didn't really see a lot of convincing bone that was growing from the L5 to S1 segment. Now, it was pretty subtle, but when I looked, I could see bone growing across L4 and L5. But at L5-S1, I really wasn't too sure. And given his symptoms, given my suspicion from the L5-S1 segment on the CT scan, I talked to him about doing a revision surgery. And what I talked to him about was actually going from the front to do an anterior lumbar interbody fusion. Now, what that would allow me to do was that would allow me to get a larger cage in. It would allow me to get more surface area for fusion by going in the front. So what we actually did for him was we did an anterior lumbar interbody fusion alone. So when we went in to do the surgery, what I first did was I removed this spacer from the front. So a vascular surgeon helped me get to the front. I removed this spacer, and even before removing the spacer, I tested to see if the bones were fused together, and they weren't. There was a little motion between them. The bones weren't completely fused together. So at that point I was pretty happy because it meant that we were there for the right reasons. So we removed the spacer, and then we actually replaced it with a larger spacer from the front with an ALIF cage. And you can see that when you compare the two, so this is him now versus before, you can see that that ALIF cage has a much bigger footprint, meaning that it's a larger cage, it gives more support, and there is more surface area for the bone to grow through and for the fusion to occur. I also took cultures, right? Meaning that I tested to see if there were any bacteria growing, because I wasn't sure. And a low-grade infection could have also been the reason he was not fusing together. Fortunately, he didn't have any infection. So in the end, we determined that this was potentially just one of those cases that doesn't fuse. Because in the end, you know, no matter what we do, nothing is perfect, including spine surgery, and sometimes people need revisions.